When examining the lumbosacral spine, it is difficult to separate the examination of the lumbar spine from the examination of the sacroiliac joint. As a consequence, we incorporate sacroiliac joint tests as a part of our examination of the entire lumbosacral complex. One might ask, what constitutes a pathological sacroiliac joint? It is our persuasion, based on what we understand, that a pathological sacroiliac joint is one that causes problems. As a consequence, we want to try and reproduce the patient's symptoms through our tests. We have a series of tests that we're going to use to try and provoke the patient's symptoms that have been demonstrated in literature to be sensitive and specific to varying degrees. The first test we want to use is the dorsolateral test, whereby we support the patient's knees over a pillow to place the sacroiliac joint in its maximum loose pack position. We ask the patient to place her forearm in the small of her back, thereby locking the lumbar spine in full extension in its maximum closed pack position. Afterwards, we're going to want to put our eminences on the ASISs on both sides while crossing our arms. Some cases may be uncomfortable in that position, and therefore you can use folded up washcloths over their ASISs. We'll place our hand there in that position, and then we will lean onto the patient and with a diffused contact to the ASISs, push her ASISs in a dorsal lateral direction. In so doing, we're putting stress on the sacroiliac joint. We'll hold it for as little as 45 seconds and up to 3 minutes. We may expect a patient's symptoms to be delayed in onset due to the stepwise creep deformation of the joint. At the end of the 3 minutes, if we've still not provoked the patient's symptoms, then we can add an overpressure. We'll ask the patient to take in a breath, let out the breath. I'll raise my head up, and at the end of her exhalation, I offer an overpressure in a dorsolateral direction. I release the dorsolateral pressure and retest the patient. The second provocation test that we'll use is the counternutation provocation test according to Ostergaard. For this test, I'm going to test the side that I'm standing on. I will flex the hip and knee to 90 degrees, then I'll let the tibia down. I'll support the opposite ASIS and provide a lean into the distal femur on the involved side and provide an axial compression on the femur. Again, this is a provocation test, so after holding it, I'll watch for the patient's provocation of symptoms. Frequently, this test is provocative early on in the test, but we can hold it for stepwise creep deformation. The third test that we might incorporate in our examination, a test that's infrequently positive for provocation, is the ventromedial test. For this test, we'll ask the patient to lie closer to us. Here, we'll place the hips and knees in 15 degrees. We'll place our mobilization hand over the lateral ventral aspect of the iliac crest and support it or reinforce it from behind with the other hand. And then in this test, we'll provide a ventral medial sustained pressure to the iliac crest. Again, we can hold it up to 3 minutes. At the end of the 3 minutes, if not provocative, we can add an overpressure. We'll ask the patient to take in a breath, let it out again, raise my head up, and then overpressure at the end of her expiration. The next provocation test that we may elect to use if we've not had a positive test up to this point is the Iaom cranial test in prone. I've uncovered the patient's gluteal region so you can see the landmarks that I'm putting my hands on during the test. Normally, it's not necessary to uncover the patient. What I'm going to do during this test is my mobilizing hand is going to be placed on the ischial tuberosity here, while my stabilizing hand will be placed over S2 on the sacrum. You'll notice that my forearms are opposite to one another, so my stabilizing hand will create a force that counters the force created by the mobilizing hand on the ischial tuberosity. Then the test is going to involve pushing the ischial tuberosity, therefore the hemipelvis and the ilium, in a cranial, lateral, and slightly ventral direction. I'll create a pressure and hold it for up to 3 minutes. At the end of 3 minutes, if I don't reproduce the patient's symptoms, then I'll add an overpressure to see if that reproduces the symptoms. Now, in the same position, I can perform an ilium caudal test. For the ilium caudal test, I'm going to go in exactly the opposite direction. For stabilization, I'll place my caudal hand over the inferior lateral sacral ankle. For my mobilizing hand, I'll place it on the iliac crest. In this test, what I'm going to do is provide a caudal pressure or force that is caudal, slightly medial, and slightly dorsal. I'll keep my stabilizing hand supinated so it doesn't get in the way of the moving hemipelvis. I'll give the force for up to 3 minutes. Wait for a provocation of the patient's symptoms, and if there's no provocation, I can add overpressure. Another component of examining the sacroiliac joint involves the appraisal of a patient's mobility in that joint. We've previously discussed the importance of provocation tests, but now we want to appraise the mobility of the joint and the hemipelvis in the pelvic ring. How stable is the system? We're going to use the active straight leg raise test to appraise that stability. The test is conducted in 2 parts. Prior to conducting the test, I want to pre-place a sacroiliac belt. We've chosen to use the SI lock that's marketed by OPTP. We place that belt around the pelvic ring, just caudal to the ASISs. Here are ASISs, and just caudal is the belt. I've not tightened the belt down yet. I want it loose for the first part of the test. I'm then going to ask the patient to perform an active straight leg raise where they lift the foot up off the mat approximately 20 to 25 centimeters. So she'll raise it up a little bit higher. Good. Let it back down again. I was showing the height. Go ahead and raise your leg up. Very good. And back down again. A positive test is a test where the patient has difficulty or impossibility in raising the leg up off the mat. On occasion, if you're suspicious of involvement and they were able to lift it up, but you suspect weakness, then you can ask the patient to lift the leg up off the mat and apply light resistance to the long lever. Back down again, we compare it to the other side. She raises the other side up, and if we used resistance in the original test, we can do so here and compare their ability to hold the leg up. Again, a positive test is one where the patient demonstrates difficulty or impossibility in raising the leg up. Well, if we see that outcome, then what I'm going to do is I'm going to now tighten the belt up to where I can get just 2 fingers underneath it. And now I'm going to ask the patient to repeat the test. She now lifts it up, and we expect in the event, and let it back down, in the event of pelvic ring instability, that she will now, with the stabilization that's provided by the belt, be able to lift her leg up off the mat. She comes up, and now if I add the resistance, it should be equalized or near equal to the other side.